Helena, thanks a lot for inviting me to give a lecture for your congress. This is an updated lecture I've given in 2022 during the Corona pandemic for the British Royal Society of Medicine. It was a session for patients as well as for healthcare professions. So we'll give you some information about the current state of the art, what is known about fibromyalgia, what we do not know, and what is uncertain, or where we have controversies in science, but which may also affect patients. So let me say a little bit about my background. So I'm working with patients with fibromyalgia since 30 years in clinical practice. And I also working together with self-help groups and organization. This is our regional self-help organization in our federal state in the Saarland, which is near France and Luxembourg. And I'm also a member of the scientific advisory board of the European Network of Fibromyalgia Associations. I do a lot of medical expertises for our social courts for fibromyalgia patients if it comes to claims for disability pension. So I have some conflicts of interest for this lecture. First of all, I have some minor financial conflicts of interest. So I always try to promote non-pharmacological therapies for fibromyalgia. Therefore, I will receive future honoraria for consulting companies for developing some non-pharmacological devices for fibromyalgia treatment. So I also have academic conflicts of interest. I was the head of the German Fibromyalgia Guidelines Group, which started in 2012. So I was member of the EULA steering committee for the European guidelines for fibromyalgia management. And I've written some systematic reviews on pharmacological as well as non-pharmacological managements of fibromyalgia, which were published in the Cochrane collaboration. So what we know about fibromyalgia, or where nearly most experts would agree. First, this is a very sad known fact. Fibromyalgia had a very bad disease prestige. This is a study which was conducted in Norway in 1990, 2002, and 2014. And fibromyalgia always ranked at the lowest level of prestige. I hope it's better in Slovenia, but in Germany we have still some reservations, especially from from family medicine, and especially from psychologists and psychiatrists against the diagnostic label fibromyalgia. So it has become better with the years in Germany with the guidelines on fibromyalgia, because the psychological, psychiatric, and psychosomatic societies, as well as the orthopedic surgeons, were involved. But nevertheless, there still are physicians from these specialties who claim that fibromyalgia does not exist. It is a psychiatric disorder, or it's an unhelpful diagnosis for patients. Of course, this is not what the guideline says, on the contrary. So what Dennis Turk, which is a very important psychologist for pain management, has even said for 30 years ago, fibromyalgia is more than tender points. So we have a very recent definition of fibromyalgia in the new international classification of diseases of the World Health Organization. And of course, fibromyalgia, one main symptom is chronic widespread pain, but also unrefreshed sleep, cognitive dysfunction, which is called fibrofog, and other somatic symptoms. And the symptoms are not better accounted for by another diagnosis. So, but fibromyalgia syndrome only is very rare. So if I see a lot of patients in the months which are presented to me with a question, is it fibromyalgia or not? And if I make a complete medical history as well as a medical examination, I have to make different diagnoses in most patients. The first, fibromyalgia is frequently associated with other chronic pain conditions like tension headache, migraine, irritable bowel syndrome, temperamental disorder, or endometriosis. Second, fibromyalgia is frequent in silent or slowly active inflammatory rheumatic disease like rheumatoid arthritis, up to 40% of patients, as well as in osteoarthritis. And many, but not all, patients with fibromyalgia meet the criteria of a mental disorder, especially depressive disorder, anxiety disorder, and post-traumatic stress disorder. And if it comes to the management, it's very important also to have assessed these comorbidities. So FMS is a common disease. We know that up to between 2 and 4% of the general population can be diagnosed with fibromyalgia, and we have a higher prevalence in special populations, let's say female patients between 40 and 60 who are hard-working jobs. So we also know that fibromyalgia is frequently underdiagnosed. We have a long journey until to diagnosis. So this is an old study, but I'm afraid that nothing has changed. That average waiting time until the diagnosis is finally made are 2 years. And we can also see this underdiagnosis between the discrepancy between the administrative prevalence, that is to say, how often this code fibromyalgia can be seen in the data of the health insurance companies, and the prevalence we can assess in surveys of the general population. We have participated in some surveys in Germany, and therefore we have data on potential fibromyalgia cases in the general population. And these are the data of Germany, though the code fibromyalgia syndrome can be found in 0.3% in the data of large health insurance companies, but it's 2.1% in the general population. And the discrepancy in the US is even greater. We also know that fibromyalgia is underdiagnosed in men. So we can see it in the ratio of women to men in clinical care centers is 8 to 10 to 1, but in the surveys in the general population, it's 2 to 1. What are the reasons? I think there's 2 main reasons, though the tender points are still used for diagnosis of fibromyalgia syndrome. I will tell you later that they should not be used. And I think more especially that fibromyalgia is regarded to be women's disease. And some physicians do not even consider that a man might suffer from fibromyalgia. So I've diagnosed fibromyalgia in men who have previous elite athletes, though. And another reason is that physicians want to avoid the stigma of fibromyalgia diagnosis in men. So we knew a lot about the prognosis of fibromyalgia from long-term studies, which last up to 30 years. We know that in most patients, there is no complete cure available. That is to say that the symptoms, chronic widespread pain, sleep disorders, and cognitive disturbances can persist, but of course they can be reduced. There are very rare complete remissions described in adults. The prognosis is better if the diagnosis is made in children and adolescents. At least 1/3 can develop a complete remission in the adulthood. It's also important to say the patients at the initial diagnosis that fibromyalgia patients have normal life expectancy. However, we see a slight increased suicide rate in female patients compared to the general population, which might be due to comorbid depressive disorder. We also know that a lot of patients with fibromyalgia have a reduced health-related quality of life and are disabled, especially if they are working in jobs with hard physical and or mental or psychological demands, but that although patients can succeed to adapt better to the symptoms and to achieve a greater life satisfaction, I will come back to the point if we talk about psychological therapies. So I've stressed before that fibromyalgia only is very rare, that it's frequently associated with inflammatory rheumatic diseases, with other chronic pain symptoms, and with mental disorders. Therefore, we also know that fibromyalgia syndrome is a very heterogeneous condition from a clinical point of view. So first, from the predominant symptoms, I know some patients who say, oh, I suffer more from the fatigue than from the widespread pain. And the second criterion for assessing the severity of fibromyalgia and to make so that this is a rather slight or moderate or severe form of fibromyalgia is just to count the number intensity of other somatic and psychological symptoms and also the amount of disability. Though, to give an example, there are patients with fibromyalgia who are able to work and to maintain their leisure activities. In contrast, the patients with severe fibromyalgia, they are not able to work and are not able for slight work in the house, and they've given up all kind of leisure activities. So if we're talking about the physiology and pathophysiology of fibromyalgia, I think at least most researchers would agree that fibromyalgia is a prototype of a nociplastic pain condition. So this article in Lancet for healthcare professionals, which I have written with colleagues from US and Canada, is freely available. So what does it mean? So we make a difference in pain medicine between nociceptive, neuropathic, and nociplastic pain conditions. So we have nociceptive pain conditions, for example, in patients with inflamed joints, for example, in rheumatoid arthritis. We have neuropathic pain conditions if there's a lesion of a peripheral nerve of the spinal cord or the brain, and then we have neuropathic pain mechanisms. And we have this nociplastic pain mechanisms, that is to say we have no nociceptive and no neuropathic pain mechanism, but the problem is in the brain and in the spinal cord. And it's a hypersensitivity and a spinal sensitization. In easy words to say, it is the brain and the spinal cord of these patients is overreactive. That is to say, it responds to external stimuli in a very exaggerated way. And we can also see this hypersensitivity by brain imaging, that we have some overactivity in some regions which are processing sensory stimuli. And so from the clinical point of view, a lot of patients with fibromyalgia, they are not only hypersensitive to pressure, but also, for example, to heat or to cold or to noise. And because there are also findings of change of the size and form of some brain regions, there's an activation of some cells in the brain with a very slow inflammation, and we have a reduced descending pain inhibition. That is to say, the brain as well as the spinal cord has a possibility to suppress sensory input from the body, from the muscle, from the joints, and this descending pain inhibition does not work perfectly in patients with fibromyalgia. That is to say, fibromyalgia is seen more disease of the central nervous system than a disease of the muscles and the tendons, even though the pain is experienced in this area. But it's important to stress that there are some patients with fibromyalgia who also have not only nociplastic, but also nociceptive pain mechanisms. And these are often patients which are older, and the fibromyalgia has started with some peripheral nociceptive input, for example, by an inflammatory rheumatic disease or by osteoarthritis. And then even if this inflammatory rheumatic disease is sufficiently treated, there's a spread of pain, and we have in these patients a secondary sensitization. In contrast, we find patients with so-called top-down mechanisms, and these are the patients where the fibromyalgia symptoms start even in childhood or adolescence. They have frequently other family members are diagnosed with chronic pain. They have also this high number of overlapping pain conditions like migraine, tension headache, temporomandibular disorders. And they are also hypersensitive to non-pain sensory stimuli, for example, noise. That is to say, we have, as I've told, fibromyalgia syndrome can be a very heterogeneous conditions, and physicians have to be aware that there can be in some patients some nociceptive pain mechanisms in the joints or of the patients. So, and if we are talking about what are the potential causes of fibromyalgia, then we come back to the biopsychosocial model, which is accepted in pain medicine, but also in psychosomatic medicine. That is to say, we know that we have an interaction between biological, psychological, and social factors. And these factors might differ between patients, though there's not only one way which leads to fibromyalgia, as it is for coronary heart and coronary heart disease or myocardial infarction. But we know that there are some typical risk factors for for myocardial infarction, like smoking, elevated blood pressure, or hypercholesterolemia. But there are the patients who have only one of these risk factors, and there are the patients who have none. And this also applies to fibromyalgia. So we know there are some predisposing factors to develop it, some risk factors. We know there's a family aggregation. There are some genes which are associated with chronic widespread pain, but there's no typical fibromyalgia gene. We know that childhood adversities like emotional neglect, but especially emotional abuse, sexual abuse, and physical abuse increase the risk of many diseases, but also fibromyalgia. We know that persistent psychosocial stress in family or in working place increases the risk of many diseases, including fibromyalgia. And we know that a disturbed sleep, or whatever the reasons are, also increase in the long run the risk to develop chronic widespread pain. So you can have predisposition, but you must not have fibromyalgia. It needs also some triggering factors. And we know that inflammatory rheumatic diseases are a triggering factor. And unfortunately, we know by the COVID-19 pandemic, that viral infections can also induce in patients with a predisposition fibromyalgia-like symptoms. So there are some studies done during the corona pandemic which have shown that some people, 3 to 4 with severe COVID-19 can develop fibromyalgia. And we know that some factors can increase the severity, have a negative impact on the clinical course of fibromyalgia, which are the behavior of family members. On the one hand, there's overprotection, and on the other hand is a lack of understanding for the symptoms of the patients. And we know if patient suffers from anxiety disorder or mental disorders, this has a negative impact on the severity of symptoms. All this is not specific for fibromyalgia. We also know that depressive disorder or anxiety disorder has a negative impact on diabetes or patients with coronary heart disease. So we also know that we should not use the 10-point count for the clinical diagnosis. My friend Fred Wolf, unfortunately has died last year, and who was the one who first defined fibromyalgia in 1990, although has stressed that we should not use it, and he finally succeeded to introduce new diagnostic criteria without this 10-point count. And the most recent criteria are the 2016 criteria, which pain in 4 or 5 body regions except head and abdomen and face. And these co-symptoms, sleep problems, unrefreshed sleep, and cognitive disturbances like concentration problems and memory problems. So we although know that the clinical diagnosis is in most patients not very difficult. It can also be made by primary physicians in most cases, and I'm very happy to see that in your program there's also some lectures on diagnosis and management of fibromyalgia in the primary care setting. So it needs a complete medical history, including medications, because some medications can mimic fibromyalgia symptoms. It needs a complete physical examination to check if there are signs of a somatic disease mimicking or contributing to the symptoms. And it needs few laboratory tests, not to confirm fibromyalgia, but to rule out and to screen for other somatic diseases. And you should only do specific laboratory tests and consultation of specialists, for example, rheumatologist or neurologist, only in case if the primary care physician suspects some somatic disease which might mimic or contribute to the symptoms. This is set in German guideline, but also in Israel or in Canada. So I've talked about the guidelines on fibromyalgia, and all these guidelines are in line that we should avoid over-medicalization. And all these recent guidelines highlight the importance of non-pharmacological therapies, especially self-management of patients, especially social support, aerobic exercise in the long-term management. Avoid over-medicalization. So I've talked about these nausea-plastic pain conditions and like irritable bowel syndrome, like tension headache. And there are some overarching principles of treatment of these conditions. That is to say, you find the same recommendation in guidelines for fibromyalgia as well as for irritable bowel syndrome or for tension headache. Again, it's the promotion of self-management. It's the continuation of life participation in work and social activities, and is to maintain good lifetime habits. Of course, all this is important for every woman, every man to maintain health, but it's especially important if you have a chronic disease, a chronic pain disorder, especially in these diseases, health adapted physical activity, diet and weight management, and proper sleep hygiene is very important. So what we do not know, but is we know that no size fits all for all in life, and all these therapies, pharmacological as well, non-pharmacological therapies which are available for fibromyalgia, they do not fit for every patient. So there are a lot of randomized controlled trials, and you have always the same tendency of results. 30 to 40% of the patients, they are responders. They report between 30 and 50% symptom reduction and improvement in physical activities. But there are also more patients who do not profit from that kind of therapy. Might it be psychological therapy, or might it be a pharmacological therapy? So we do know what we do not know, what predicts if a patient responds to treatments or if he fails. So to my opinion, with my personal opinion, we have to make a movement towards a more precise psychological as well as pharmacological treatments. And at least in theory, we have a lot of different type of psychological therapies available. Those standards, cognitive behavioral therapy, CBT. And I told you that there are frequently mental disorders associated with fibromyalgia, like anxiety and disorders and depressive disorders. And there are these special adapted psychological therapies available for depression and anxiety disorders. And a patient with a comorbid mental disorder should receive these therapies. There are special techniques available for patients with post-traumatic stress disorder. But other patients might have a maladaptive coping, for example, catastrophizing, constant exaggerated fears and avoidance behavior. And there are also special therapies available. Some patients with fibromyalgia, they still suffer from unresolved emotional issues, which might contribute to the pain. And again, we have special therapies available, even demonstrated their efficacy in randomized controlled trials like emotional awareness and expression therapy, which can help. And we have for self-management, hypnosis and mindfulness-based stress reduction. And I showed you, I've developed a CD audio file with medical hypnosis for fibromyalgia patients 15 years ago, which patient can use for self-management in adjunct to other therapies. So this should be the movement in the future, to my experience. Okay, I assume that a lot of us say, okay, where are these therapies, psychological therapies available in Slovenia? I know that some of these therapies are very rarely available in Germany. CBT is broadly available, but these therapies are rarely available. And I would draw to attention to a very recent study which has been published in Lancet, which is the best well-known medical journal. And it's a special kind of psychological therapy which is based on acceptance and commitment therapy on a digital health device. And it has been really proven in a study to be effective. And in Germany, we have already these devices available, and I can describe that digital health application for patients with fibromyalgia. This is in German, which offers this psychological therapy of acceptance and commitment therapy. And I hope that these devices will also be available in other countries and be translated in other languages. So, and if you are talking about a more precise therapy, it also applies to pharmacological therapy. And this is what the EULA guidelines say. We should consider the key symptoms, but also the comorbidities of the patients and his preferences and the view of potential side effects. To give a few examples, so if sleep problems are a major problem for the patients, so we would prefer amitriptyline or pregabalin because it's also effective for sleep disturbances, in contrast to duloxetine. These three medications have been duloxetine, pregabalin, and milnacipran have been approved in USA and other countries except Europe for the treatment of fibromyalgia. So in contrast, so if a patient also suffers from depression, we should prefer duloxetine. And another point to consider are somatic comorbidities. So therefore, you should not describe duloxetine with a patient with a severe liver disease. And pregabalin, it might cause somnolence, and it's not allowed to prescribe it for professional drivers in most countries of the world. And patients' preferences are also important. Weight gain is an important topic for a lot of women age between 14 and 16, and you have to consider and to say to the patients that amitriptyline or pregabalin can induce weight gain. So I come to the last point, the uncertain, or what are the controversies about fibromyalgia. First, I have to say that controversies and different point of views are important in science, but it can have a negative impact on patients if these controversies induce uncertainties of the patients, and if they inhibit them to do these things which are important in the guidelines, disease management, and if these new findings induce the hope of patients that there will be find a magic pill which can relieve all fibromyalgia symptoms. So we have two main controversies on the etiology, on the cause of fibromyalgia. So my colleagues, Claudia Sommer, a neurologist in Germany, was the first to publish a study which have shown that there is a reduced nerve fiber density in the skin of fibromyalgia patients. And you can also have this finding of a reduced density of nerve fibers in some patients with a special kind of neurological disease, the polyneuropathy. But these findings can also be only demonstrated in subgroup of fibromyalgia patients between 50 and 60%. But so there have been a discussion, though some neurologists claim that fibromyalgia is nothing than a small fiber polyneuropathy, and in the US, these patients have been treated by very aggressive medications, which are also have been used for treating of cancer. So therefore, it's important to stress that these findings of a reduced skin innervation can also be detected in many non-painful diseases. It's not a specific finding for fibromyalgia, and that this reduced skin innervation is associated with changes in the morphology and connectivity of brain regions, and which goes along to the mainly accepted theory that fibromyalgia is mainly a disorder of increased sensitivity of the brain and the spinal cord. And the last point, there are patients with this neurological disease, but their symptoms are a little bit different from the ones of patients with fibromyalgia. So a very recent new theory has come also from a German who was a professor in Liverpool in the United Kingdom. And he claimed that he took some blood from patients with fibromyalgia, and he extracted some antibodies and injected these antibodies into mice and found that they have painful sensory hypersensitivity. And he suggested that some new therapy, which antibodies against this antibodies may be effective for fibromyalgia. And this again have induced some hope of patients that a new, probably very expensive therapy might heal them. So, but there are very serious arguments against this, that fibromyalgia is an autoimmune disease and is caused by antibodies against some tissues in the body. Because classic inflammatory indices in the blood or clinical examination are normal in fibromyalgia patients, and we know that up to 40% in patients with inflammatory rheumatic disease have chronic widespread pain and fibromyalgia symptoms, despite they are treated with the most powerful immunosuppressive agents, and these medications did not reduce the pain. Though the very Dan Claw, which is one of the leading scientists in the world of about fibromyalgia, has written a very interesting article against this theory. Though, therefore, I advise patients that they should not be troubled by these new findings. Our scientific discussion is not finished yet, and until now, from these findings, there are no consequences for therapy. So I want to thank you for your attention, and I've stressed the importance of self-management and self-help organizations. And we have in Germany the problem that our fibromyalgia self-help organizations is very split. We have different one, and if you have many different ones with different voices, you have not enough physical, not enough political impact. So I hope you have a very strong and only one Slovenian self-help organizations for fibromyalgia. Finally, so if you want to find some quality assured information about fibromyalgia, which we distribute in Germany, quality assured from the German Ministry of Health, it's available in English, and these guideline recommendations, which I have presented for you, you can also read it again in Germany. So I wish you all the best for the future and have an interesting conference. Bye.